Thank you, Jim, for the kind introduction and for this great opportunity to come back to New York. As you can see here, for my disclosures, I'm co-founder of Vascupedia. Just to let you know, Vascupedia is a platform, internet platform about vascular disease, treatment and diagnosis, just launched June the 1st. Please have a look to this internet platform, make some suggestion how we can do it better. Now back to the topic. If you have an anatomy like this with a straight neck, with a neck longer than 15 millimeters, a good access, well, you can use any endovascular device you are familiar with. The problems are somewhere else at the level of the neck and at the level of the axis. And starting now with the neck, how we choose our endograft in a short or angulated neck. Well, you addressed this topic at the beginning, Jim. Our method would be, if we use a suprarenal fixation of the graft, we use the so-called Japanese method. So we open slightly the first portion of the graft, and we push a bit the endograft in the curvature so that the graft accommodates much better in the angulation. And it's mandatory to use an endograft with a high anatomical conformability and with the delivery system which allows you to deploy very exactly, very precise the stent graft at this level. We should discuss it later on. What about short neck? Well, for short necks, we have many different options. And one option would be the endo anchors. I have to say we don't have really good data about this method. We have just some evaluation of a subgroup of the anchor study dealing with the infrarenal necks between 4 and 10 millimeters. These results have not been published so far. This is probably the first time you see that the freedom from secondary endovascular procedure was very high, and also the freedom from all-cause mortality, very good, actually. And these are results, especially in terms of type 1 endoleak at 1 month and at 1 year. So very interesting results, but we should discuss later on this technique if it's valuable for our practice. If we have a distance between the two renal arteries, you see here the origin of the right and of the left renal artery. Well, in this would be a case in our institution where we would use Shiva, because only one target vessel must be addressed, and the results with the one parallel graft are really good. The more the chimney grafts you have to implant, the higher the rate of type 1 endoleak and of limbocclusion. So this would be a good option for parallel grafts at our institution. The third possibility is to use a fenestrated graft, like in this patient treated many years ago. It was one of the first patients treated with excellent results also on long terms. What is the best solution for such patients? Well, we should use anatomical criteria, but also general criteria, operator dependent, and we should also observe hospital aspects. And the question is, do you have access and experience with the fenestrated grafts or with the endo anchors? What about the costs of the endo anchors? Are you familiar with the visceral or renal cannulation? These are also important aspects we should consider choosing the best way for these patients, in in my eyes. And also patient-related aspects like urgency, the patient's wish plays an increasing role, at least in Europe, the comorbidities of this patient, and also the life expectancy of the patient itself. Do we need an acute solution and we cannot wait? Well, fever would be not an option for such patient. So these aspects are multiple, and we created an approach, a criteria method to discuss what would be the best solution for the individual patient, and we published this in Journal of Endovascular Therapy recently. And now we should go to the iliacs, to the axis, and for anatomies like this, with the tortuosity, with the calcification, with stenosis of such patients, well, we need not only a graft with improved flexibility, but we need also low-profile endografts. And the low profile is of great advantage, not only for the patient, less trauma, less bleeding, less wound complication and discomfort for the patient, but also for the doctor, because he can use the percutaneous access. We had the wonderful presentation of Dr. Schneider, just local anesthesia, which is important, especially in patients with rupture. The patient can go home earlier, and we can increase the applicability. And if we consider 45,000 M2S files of these patients, well, if we go with our delivery system to 14 French, well, almost all patients can be treated by endovascular technique. And this is the reason why so many companies decided to reduce the profile of their endografts. And the methods used are very different, change to TriFab, for example, or a different stent design, or reducing the dacron weave and the polyester, and also changing the nitinol or switching from the stainless steel to nitinol for reducing the endograft. But the question of Dr. Bessin is extremely important. All these changes must balance low profile with durability of AAA exclusions. And in other words, is there a trade-off with low-profile stent grafts? What about the endoleak rate during the follow-up, especially of type 3 and type 4? And do we increase the rate of secondary procedure using this low-profile endograft? Meanwhile, we have late results. For example, of the Cordis device, we have the 5-year results showing excellent results in terms of freedom from migration, freedom from fracture, and freedom from type 1 endoleak. Another point is the behavior of the endograft at the level of the iliacs. So we don't want to see this type of problems which were observed in the past and have to be corrected. We don't want to see wire break like we saw using the Talent. So we need for this a flexible nitinol stent graft which accommodates the curvature like in this case. But not every flexible stent graft performs well during follow-up. You see here the Anaconda device implanted in this patient, and you see the angiography was not bad. The operator went down to the iliac bifurcation, which is extremely important in using flexible stent graft. But you see, the patient had to be treated again because of type 1B endoleak from the left side, and then he developed a type 1B endoleak also from the right side. and at the end, the operator had to sacrifice the hypogastric arteries on both sides. And this is what we don't want to do in these patients. In summary, ladies and gentlemen, which endoprosthesis? Well, we need an endograft with a high anatomical conformability, with controlled and precise deployment, with resistance against the migration, and with low profile, but also with increased durability. Thank you for your attention.